Okay, I can't see any of you, so but do kind of feel that you can unmute if you've got any questions, or we'll have some time at the end anyway. But as I say, I can't see at all. But so I'm Tracy, and I'm going to talk to you today about neuropathic pain, and we're going to cover what is neuropathic pain, potential causes, assessment, general management, pharmacological management, and also thinking about like non-pharmacological techniques, and then 3 case studies at the end. So just thinking about what is neuropathic pain. So it occurs when the nervous system malfunctions or is damaged, causing nerves to send incorrect pain signals to the brain and the spinal cord. And what we will have seen in practice is it can affect the peripheral nerves kind of throughout the body, or the
Has this frozen for anyone else?
Yeah,
Yes.
it's frozen for me.
Yeah, has it frozen for everybody?
Yeah.
Kate, I don't know.
I'll message Tracy and let her know.
Yeah, thank you, Sarah. Bear with, isn't technology?
Sorry, can you hear me now?
Yes. Yeah, you froze for a bit.
Do you know, the only reason I knew as well is because it was making that noise in the background, that like you've got a connection. I was like, I think I'm talking to myself. Sorry, everybody.
I think we got to peripheral nerves the first time you said it.
Ta-da! Okay, sorry. Or sensory in the nervous system in the brain and spinal cord. What we would have seen in our patients is that it can be continuous in nature and presentation, or episodic. And we would have heard kind of the words of that burning, stabbing, electric shock, tingling, or numbness sensation. And then when you think about neuropathic pain, it can be caused by a lesion or a disease affecting the somatosensory nervous system, which is different to that nociceptive pain, which results from actual threatened tissue damage. So like I cut my finger or I bash my hand and, oh, that hurt, I've got pain. Neuropathic pain arises because the nervous system itself is damaged or it's functioning abnormally. And kind of that just shows you in that image the sort of difference in the types of pain experience. So just thinking about the causes, so nerve injury or disease damages peripheral or central sensory pathways. You can get that abnormal signaling, which develops with the injured nerves, which then fire spontaneously and can become hypersensitive. Or that central sensitization, so it amplifies pain processing in the spinal cord and brain, so that your normal sensory input may be perceived as painful. So like, you know, I touch my hand, it would normally feel okay, but actually that normal sensation of touch feels very different because something's not right with my, you know, with the nerves. So if we think about it as a faulty electrical wiring, like instead of accurately transmitting information, those damaged nerves generate incorrect pain signals, and they can amplify those normal signals that we would normally experience as okay. So the International Association for the Study of Pain it kind of stipulates that a diagnosis of neuropathic pain can be diagnosed when, one, there's a plausible neuroanatomical relevant distribution of symptoms and a known lesion or disease capable of causing somatosensory damage. So I guess the patient groups we'll have is our those with a cancer diagnosis, or those without a cancer diagnosis. It could be tumor related or surgery, or it could be neurodegenerative kind of in nature. And arises from that nerve injury, disease, or abnormal processing. And it shares that it could be considered chronic when it lasts longer than a 3-month time period. So if we think about the adult population, neuropathic pain would often come with conditions like diabetes or shingles, or could be post a stroke, where they'll explain that they've got that kind of new symptom burden and experience. Whereas in children, the causes can often be different and varied, and could be medical conditions such as sickle cell, genetic disorders, or those cancers that I mentioned. Could be secondary to injuries from a surgery, that could be cancer related, but could also be from a broken bone or something where they cause damage to the nerve during that surgery process. Could be secondary to accidents during birth, and also from treatments associated with cancers, like some of those chemotherapies. I'll come on to that a bit more in a minute. And kind of having a look, kind of research shows that 1 in 5 children and teens live with some form of chronic pain. This would be associated with their muscles, joints, headaches, or abdominal pain. But actually, it's not known how many children live with neuropathic pain specifically. So then thinking about a bit more about those causes, so it could be direct infiltration of the peripheral nerves, that polyneuropathy from malnutrition, and we'll see that in our patient groups, both from the cancer and non-cancer. You can get damage to the peripheral nerves. Sort of malnutrition leads to vitamin deficiencies, particularly in B1, B6, B12, and folate, which are all essential for the nerve function. And then your chemotherapy-induced neuropathy. So some drugs are toxic to the nerves and damage them. And I've just done that sort of pop box to the side, some of which you'll have had that exposure and experience of those kind of chemotherapy culprits that cause this, really horrible experience for these children, young people. And then your cancer surgery. So when a tumor is removed surgically, nearby nerves can be removed with the tumor. They could be stretched, compressed, or in fact trapped in the scar tissue afterwards. So you may well hear after surgery the importance of like massaging around scar tissue to try and break it down, because it can impact on your nerves if scar tissue is allowed to build up. Your radiotherapy can directly cause damage to the nerves. And then herpes zoster. So suppressed immune system sort of during chemotherapy means that children are more likely to develop varicella zoster virus, and this can also then damage the sensory nerves. So just looking at this again, the sort of that injury that can occur. So all these mechanisms are damaged, that can damage sensory nerves, meaning that they can fire spontaneously, fire too often, or fire just in a disorganized way, causing your brain to interpret these signals as pain. So we think about our patient population and how they might describe, or we might see displays of neuropathic pain. So it can be difficult for young children, particularly, to kind of find the right words for what they're experiencing. But some of the words that are used, I've visited some of these already, but that kind of burning, shooting, stabbing, tingling, and numbness and itching. And it's not like I've got an itch, I just give it a scratch and it's got better. It's like an intense itching. Pain from light touch, and increased pain from those normal stimuli that would be tolerated really well. And then if we think about the children with severe neurological impairment, you might say parents say they've noticed a change in their behavior from a sensory perspective. So like when I brush their hair normally, they're absolutely fine, or when I touch and do massage, they're fine, but actually they're grimacing or they're pulling away. And that distress is not understood or known, it feels new. Okay, so why does it matter clinically? So it's often chronic and persistent. It can affect so many other things, as any pain types can, but with that neuropathic pain, it can impair their sleep, their mood, their kind of mobility overall. If you've got neuropathic pain in your feet, you'll be less inclined to want to stand on them. So then just all that secondary impact, and then it impacts on the quality of life and how they can engage with other things. It's frequently under-recognized, and that is because, generally speaking, we'll think about lots of other pain triggers and reasons before we get kind of down the line to think about that neuropathic pain. It responds poorly to standard analgesics. So I guess for kids, whilst we're working our way through our standardized approaching, they're thinking it still hurts. So they're going to have to wait a little bit of time before we kind of make a differential diagnosis, which can be really difficult. And it requires targeted treatments, and the importance of that multidisciplinary management approaches to neuropathic pain for that kind of quality of life, that mood and the mobility, where we'll need other professionals, but I'll come to that. So thinking about treatments, so treatment of neuropathic pain, so disease-directed treatment, excuse me, sorry. So chemotherapy, radiotherapy, surgery for the tumor. If you've got something pressing on, on those nerves that's causing that pain, then any of those can help. Then there's non-pharmacological. So again, where I was saying about thinking about that multidisciplinary approach, your physiotherapists, your OTs, those psychological techniques, how to manage pain, because it's not always a quick fix and something to get rid of. So actually, how can you empower them to help to kind of help manage it, really? And then thinking about the importance of massage, which again can feel counterintuitive. You think it hurts and now you want me to massage it, or it feels really awful and you want me to put something hot on it and then something cold on it. But actually that can really help with the switch off of the nerves if you switch between that hot and cold, and massage could feed into sort of desensitization. And then pharmacological approaches, of course, we can think from that as a symptomatic treatment approach. So important things to consider and think about is your patient education. I know this can be harder in our neurodisability population, but I guess in hand with that then is then parent education. But those that can talk to you about their pain, thinking about what feels important to them, what feels manageable, and kind of coming up with an agreed approach to like your non-negotiables to kind of help yourself on this journey. And if you're not up to it, which things can slip. And I think it's about having that conversation of what feels manageable because it's their pain experience. And where you can, treat the underlying cause where possible. And then your pharmacological approaches, such as antidepressants or anticonvulsants, depending on the conditions and guidelines. Think about your topical therapy. So alongside your massage, you can use menthol creams and rubs. Again, some tolerate that quite well and quite like that sensation. Sometimes this is about distraction as much as anything, or you can use like capsaicin and use that as part of the massage as a way of managing the pain. And then your physical rehabilitation, it can affect balance, so many things. So the importance of trying to keep them as well as you can alongside them managing these episodes. And then looking to your sort of your colleagues from a psychosocial perspective and thinking about any support that may well be needed. And because if you've got a patient locally is thinking about, is this beyond the sort of sphere of competence of what we've got available, and do you need to be looking at referring on to pain specialists for their thoughts and input? And I've just put a link there to the APPM formulary, which I'm sure most of you are aware of. So then thinking about those management plans for neuropathic pain, and this is relevant to both cancer and those with a non-cancer diagnosis. So looking at the WHO analgesic ladder would guide us to think about mild pain and then that moderate and severe pain, which I won't go into because that's kind of a session all on its own. But if you've got a pain kind of scoring of 1 to 4, you can use your paracetamol, but importantly thinking about those with cancer if they're not neutropenic, and plus or minus an adjuvant. And then your moderate to severe pain, so your 5 to 10 upwards, would be use of the neuropathic agent, and then a strong opioid that you could use PRN, or look at a longer acting neuropathic agent, look at longer acting as the neuropathic agent takes effect. So a bit more about pharmacological management. So you've got your strong opioids, then your gabapentoids, so your gabapentin, your pregabalin, and then amitriptyline, ketamine, and then methadone. And kind of just a note from me, really important to think about medication regimes. They can get complex really, really quickly. So remembering to deprescribe where needed. And even if you're not in charge of deprescribing, if you're looking, thinking, gosh, do they really need to be all on all of these medications, or is that even helpful anymore? Or you're hearing that from the children, young people themselves or their families, kind of go back to a clinician that can help with that, because we're collectively together, kind of that holistic approach of thinking about not having unnecessary medications and burden around that. So looking at your strong opioids, you've got your morphine, oxycodone, fentanyl, diamorphine, and as we well know, they can be given by different routes. So just kind of thinking about what's best for the situation that's kind of in front of you. And then think about the impact of those strong opioids. So on your spinal cord, you've got your presynaptic nerve, where it binds to the opioid receptors on the presynaptic nerve, and you've got that reduction in neurotransmitter release. And then the postsynaptic nerve, where it binds to the opioid receptor on the postsynaptic nerve. Your neuron becomes less excitable, neuron is less likely to fire an action potential, and then it dampens that pain transmission. And then the effect on the brainstem is activate the descending inhibitory pathways, and then the brain alters that pain, that sort of perception of pain itself. And then think about gabapentin or pregabalin, which I'm sure we've all seen used in practice. So it reduces the release of glutamate in the sensory nerves and dampens down those pain signals in the brain. But just being mindful that the route of administration of those medications is oral only. So I think we probably collectively agree to see gabapentin used a bit more, but because there is more evidence in its use, and generally is this a sort of start point. It's licensed and used from 6 years and upwards, but not for neuropathic pain. It was originally kind of it's for use in seizures, but has found over lots of cases and experience to be really, really helpful in that neuropathic population. And then your pregabalin, so it works faster, 7 days versus 14, anxiolytic. The dosing frequency is less, and it's possibly less sedative. Important to note that pregabalin is not in the BNFC, but it can be found in the APPM formulary. And in the kind of patient group of young people, they often prefer the pregabalin because the gabapentin's 3 times a day, pregabalin at twice a day. So if they're still accessing education things, it just means they haven't got to do something else, I guess, that makes their day different to others by going and getting that medication. And then amitriptyline, tricyclic antidepressant, again, oral only, and that mechanism of increasing the descending pain inhibition. It works at low doses compared with the dose that you would give for antidepressants. And generally speaking, when we start it, we'll start it at nighttime, especially when there's issues associated with sleep. So it can be good for the neuropathic pain if it's associated with sleep problems. Onset of action up to 4 weeks. But then thinking about things to be mindful of. So from a cardiac perspective, it can prolong the cardiac conduction, e.g. the QT intervals. From a renal perspective, it's partly excreted by the kidneys, so renal impairment can lead to drug accumulation. So you need to think about that. And then your liver disease is metabolized in the liver, so impaired liver function leads to drug accumulation also. And then thinking about the neurodisability population, it's anticholinergic, so it can have an impact on the gut and slow things down. And then side effects, you've got sedation, constipation, delirium, and that risk associated with low mood, so it can lead to suicidal risk and thoughts. And then looking at ketamine. Ketamine is an anesthetic medication, which has got analgesic properties, and it blocks the excitatory NMDA receptors, which dampens down those pain signals. It can be given oral, IV, subcut, buccal, PR, so much more flexible drug to kind of use in practice. And the entral onset of action is 30 minutes. So it works quickly and lasts 4 to 6 hours. Can also be used as a rapid antidepressant. So you're being mindful with ketamine around side effects of raised blood pressure and heart rate due to sympathetic nervous system activation. So just being cautious in patients with cardiac disorders, and hallucinations is a side effect, but rarely seen in the pediatric population. And then thinking about avoiding long-term use in non-life limited children because of the long-term psychiatric and cognitive effects. So yeah, just making sure under regular review about doing the right things. And then methadone. I do not claim to be an expert in methadone. And again, it's a topic all on its own by somebody that would not be me to talk to you about methadone. Be most likely to be used in the oncology population. It's broad activity and covers those different pain types. It's an opioid receptor antagonist and MMDA receptor antagonist. So it enhances the descending inhibition, very similar to what I explained, like in the amitriptyline. It's long acting, so 8 to 12 hours post-dose, and it's got really long half-life. It's been given by different routes. So again, it's flexible. But when thinking about the dosing, the relative potency of methadone increases as equivalent dose of morphine increase. So it needs really, really careful supervision by a specialist team around adding methadone in and thinking about that accumulation given the long half-life. So the titration, just needs that careful watch. There can be different methods of converting when they've been on opioids, and then you're going to consider use of methadone. So you can do a reduction and replace. You could do a rapid conversion, sort of a start-stop, or use it as an adjuvant. And I would say this is where I've most likely seen it used in practice is you've got an opioid already in, and then their doses are climbing and climbing and climbing, and then methadone comes in to try and offset that. So the side effects are similar to other opioids, and actually as a medication itself, it is cheap in cost. So I thought we'd visit some case studies. So case study A is a 4-year-old boy with BALL on oral morphine, 2.5 milligrams as required for bone-associated pain. They commenced on their induction therapy, which included vincristine, and as we looked at in the slides earlier, vincristine is one of those chemotherapies that can lead to neuropathic pain, also on asparaginase and steroids. So complained of tingling feeling in hands and feet and unable to play games on iPad. And this is where it comes into then affecting the quality of life, because actually if this young man uses playing those games as a distraction in around his cancer treatment, and then that's kind of taken away, thinking about how can we get that better so he can engage in those things that are kind of keeping him kind of mental health and well-being. So commenced on gabapentin, 150 milligrams 3 times a day. And actually what was seen is there was an improvement in symptoms and able to wean the gabapentin towards the end of treatment. And sometimes what you'll see is that you need to put things in place when certain chemotherapies are due, and then things can ease off and then increase back up. So then we had a 16-year-old with a nasopharyngeal tumour who commenced some chemotherapy and radiotherapy in January of 2025 and was referred to the symptom care team for a pain that he explained as like a finger pushing my eye out from the inside. So you can see that like the language normally associated with neuropathic pain is quite a bit more colourful than other types of pain where they might say, I've got a bit of an ache in my back or my knee hurts a little bit. So commenced on Severodol, which is morphine, 10 milligrams as required, and also a fentanyl patch for that longer acting approach to pain medication, and then high dose dexamethasone. In the February, the symptoms improved and they're able to reduce and stop the fentanyl patch. Again, back to my point, don't leave things in that aren't necessary. It's good to keep things under review. And then looking at the July, sort of 6 months in, PET scan showed T3 bony met and commenced immunotherapy and chemotherapy for a relapse. She started to complain of pain at T3 and regular oxycodone and lidocaine patches were used, and the fentanyl patch was put back in place and kind of increased and decreased over the next few months, depending on the symptom presentation. And then in the December, sort of escalating sharp pain, and the MRI showed further metastases in the spine. So stopped immunotherapy and restarted chemotherapy and commenced on some pregabalin at 50 milligrams twice a day. And then in the January, the fentanyl patch and pregabalin increased as requiring more breakthrough oxycodone. So it's just kind of looking at the overall picture and seeing what's the right thing to kind of do within the jigsaw. And then in the February, started weaning the fentanyl patches as things started to improve. And then looking at a non-cancer diagnosis, so a 10-year-old female with giant optional neuropathy, and the variant of her GAN is unknown. So the significance of it is like it's causing extreme symptoms for her. She had EMG and nerve conduction studies, which showed neuropathy affecting predominantly the legs, but also her arms, and she was complaining of headaches as well. Really quite debilitating for her. And within that nerve conduction testing, it demonstrated that amitriptyline, it's very clever, I don't know how it all works, but demonstrated that amitriptyline would be likely the most beneficial neuropathic agent. But at the point we met her, she'd already had gabapentin, had increased that dose up without benefit, then moved on to pregabalin, had done the same, increased up without any benefit, and then was just switching on to the amitriptyline and was increasing. And what's happened since then is she's increased on that and it didn't add any benefit. So again, that importance of the MDT approach, and then speaking back to other teams as well. So just again, commenced on carbamazepine. So you can see how sometimes it gets complicated and you have to move through different medications. I guess just as an aside for her, commenced on BiPAP as well due to weakened respiratory system. So kind of lots going on for her. So in thinking about non-pharmacological approaches and wider well-being, she's been really good at engaging in massage, despite the fact that sometimes it's incredibly uncomfortable. And that sort of touch, using different things. So you can use feathers, you can use sort of different materials to kind of say it's your foot or your lower leg to like run along. Just all different sensations that are trying to switch off those nerves. Heat-based creams, I mean, she did them all without any benefit, and that moving between hot and cold, and like that importance of trying to do some desensitization. All of this collectively led to kind of low mood. The diagnosis in itself is very, very difficult, and all the associated symptoms. So the psychological impact of that, and this is case studies kind of in a nutshell, but thinking about, she's engaged in art therapy, coming into lots of different professionals to try and kind of help herself as much as possible, which is where you kind of can have that conversation, that agreement around kind of what can you do and what can I do. But actually she's been assessed and started on sertraline. I'm thinking for her about next steps. We could use ketamine, that hasn't been used yet. And there was some advice given around the addition of the sertraline and how it can enhance the effect of the other neuropathic agents. So we could actually consider retrying the amitriptyline and also see the benefit on the medications as the sertraline increases alongside. So just then thinking about neuropathic pain, it's not simply pain that lasts a long time. It is a pain generated by a damaged nervous system. Recognizing its characteristic symptoms and mechanisms allow us to diagnose it earlier, choose appropriate treatments, and improve patients' quality of life. And I've absolutely whizzed through that. I don't know if anyone's got any questions or thoughts. Alison. Can't hear you.
Thank you so much for that,
Oh,
Tracy. That was really interesting. Because of would you suspect it's quite undiagnosed in our population that find it really hard that can't communicate reliably, both to kind of notice that it's going on, but also because the treatments are it relies on their response to it.
Yeah, I agree with you. I think it's really difficult in those that have got altered kind of neurology or ability to kind of communicate with us. I think it is tricky, and I think you could be right. And also, we're moving through our process of you've got a pain and you'll go to many other things before you get to that down your list. Sometimes it's quite obvious, but sometimes not. I think the other kind of tricky with any of that pain is you can't get anything back as to what's helpful and what's not. It's a lot of kind of watching and learning. But I would imagine, given that the research shows that they don't know how many children are affected by neuropathic pain, then I would imagine it goes undiagnosed, and they're not able to use those descriptive words for us that would help us kind of go, okay, this is neuropathic. So I think it is tricky, and having had some nerve pain myself, it's grim. And so I think for them as well, if they've got that untreated, and also as well, you can't explain to them, I'm going to do some massage to try and switch off your nerves. They're thinking, why are you touching me? And doing that, it really, really hurts. So I think it is really difficult. But I think it's a really good point. I think it probably does go kind of lost in other things. And we've got vulnerability points as well, right? Quite a lot of our can be malnourished at one time or another, and kind of thinking about all of those things as well. So there are also kind of points of vulnerability. Okay. I don't know if it's Sarah.
Sorry, you mentioned about, obviously you spoke a lot about non-pharmacological pain, and I don't know whether you can answer this, but is this where things like acupuncture and stuff have quite a lot?
You can
help?
It can be considered, and I think then it's like for the neurodisability population, it can be difficult because, again, getting them to engage and keep still in some of those things. I think you'd have to have a patient that had cognition that you can have an agreement around kind of acupuncture approaches. I think some of it, as well as those complementary therapies, is access to different types of complementary therapy. I think has always been stretched, but is stretched more than ever to be able to think about that. So actually, some of the things that you might offer kind of can't because it's not available, but you can absolutely consider use of acupuncture. Actually, I didn't mention it in that last case study. She's trying some acupuncture at the minute, but nothing seems to be helping, which is really difficult. But even, I think, to your point, Sarah, even if you do some of those complementary therapies anyway, and it's another platform to just be able to talk, also is really important to kind of have that protected time to talk about your experiences or how you are and those kind of things as well. So yeah, I didn't mention complementary therapies. Thank you.
No, but I think on your point, that is a good point, isn't it? Because if you think of pain as a whole, you've got to think about the psychological pain as well.
Yeah.
And neuropathic pain must have a massive impact on someone's psychological health as well.
Yeah. Yeah, for sure. For sure. I think living with any type of chronic pain is difficult.
Yes.
I don't know if anyone's got any other questions, thoughts, reflections, anything I didn't make sense on. I don't claim to be, expert in these topics and areas, but, if there's something you want to know and I don't know it, I can find out and kind of come back to you on it.
I found that really useful. Thank you. I learned a lot in that.
Thank you.
I know Alison's had to drop off, so I've said that I kind of keep an eye on the chat box and stuff for her, but does anyone else have any comments Does our colleagues from Demelza have any comments or anything to add?
No, it's really interesting. Like you say, neuropathic pain seems to be really tricky to get on top of and try and work out what's going to work and what's not.
Yeah, I agree. Okay, well, if we're finished, then that gives you all a bit of time back, doesn't it? That doesn't happen very often. So, but thanks for coming. And yeah, if you think of anything, I'm always, just reach out. Happy to answer questions. But thanks, guys.
Thanks,
Thanks, Tracy.
Have we got to stop the recording, Sarah?
I don't know. I'm going to try.
Alison started it. Can we stop it?
I've stopped it, I think.
Oh, well done.